So, aloha everybody, and mahalo to the organizers for inviting me to present our work on simultaneous intracranial stimulation and using fMRI. I just want to briefly say that although I'm involved in this work, the majority of the stuff that I'm about to show you is driven by Dr. Steve Jones at the Cleveland Clinic, and he couldn't be here to present this, so I'm presenting on his behalf. I don't want to discuss this in too much detail other than just to say that the work here is the result of a large collaboration amongst various neurosurgeons, radiologists, physicists, and neurologists at the Cleveland Clinic. So motivation for this kind of study is that, as I'm sure a lot of you know, focal epilepsy is a very debilitating disease, but it is potentially curative. There's an enormous benefit from identifying the epileptogenic zone in focal epilepsy. And so essentially, any method that can identify this can actually be very beneficial to the patient. And so our goal was to develop methods that can complement the current invasive intracranial procedures. And we'll show that, that methods like this can actually have other applications as well. So the goal of CCEPs, of performing cortical evoked potentials, is to basically insert depth electrodes into the brain and then stimulate the cortex, the idea being that this will actually cause firing in other areas of cortex, particularly if you happen to be stimulating in an epileptogenic focus. At the Cleveland Clinic, we've developed a technique called the stereotactic EEG, or SEEG. And so our hypothesis is that with these depth electrodes, we using bold imaging, you should be able to monitor the patterns that you get cortically from the activation that's stimulated by the depth electrode. Now, the normal clinical stream for patients selected for this procedure is that initially they're sent to the OR for insertion of the SEEG array. Then there's a period of 2 to 3 weeks where they're evaluated with continuous stimulation and monitoring in the ICU. Then the team forms a hypothesis with regard to where the epileptogenic focus is. They're taken back to the operating room where the SEEG array is removed. A surgical plan is developed, and then about 2 months after the SEEG array is removed, they return for resection. Our process in intervening in this and trying to develop fMRI methods is that in the stage where the SEEG array is removed, what happens is the CCEP of the epileptogenic zone is left in, so all of the other electrodes are removed. We then do direct electrode stimulation with that array while we're doing simultaneous fMRI monitoring. And then once we're done with that, then the remaining SEEG is removed and things are closed up, they're discharged and come back as usual for their 2-month surgery. Some more details. Basically, in the OR, all the monitoring is done under general anesthesia. We do 4 runs of direct electrical stimulation using 2 separate locations, an epileptogenic zone location and a non-EZ zone, and we typically do this with two different current settings. And then immediately prior to the pre-section, we perform high-resolution diffusion imaging and resting state fMRI. Shown here is sort of the process. Here's our IMRIS intra-operative suite. The patient's placed on the table here. And so at this stage, in this part of the procedure, the SEEG array is being removed. So they're placed on the table. All of the electrodes except for one are removed. Then we advance the MRI scanner into the suite over the patient's head and then perform the direct electrical stimulation. We've performed extensive safety testing along the lines of what was shown earlier by Hiroyuki. We have an anthropomorphic phantom with gel that has bioelectric properties similar to brain tissue. We place the electrodes to be implanted in this gel in a similar orientation similar to what's going to be used intraoperatively. And shown here are the fluoroscopic monitoring probes that are put proximal to the contacts. And then what we do is similar to what was described before. We basically put this in this setup in the scanner, and monitor the temperature changes. And the things that we've learned is that it's very important to keep the cables very centered along the transmit isocenter of the scanner, and not perform, as was discussed earlier, very high SAR procedures. The other thing that we discovered is that it's very important that all the cables are terminated. If you actually have if you have a non-terminated cable or a floating cable, this can cause a lot of heating issues. More details on the protocol. We typically run an MP range for anatomic detail and our gradient echoplanar acquisition for our bold weighting. This is being done at 1.5 Tesla, so we have to keep the voxel size pretty large so that we have good contrast to noise ratio for bold. As I said before, we do 4 runs. The stimulation design is 32-second blocks at 20 hertz, and I'll say more about the frequency and the importance of the frequency domain in a minute. 0.3 millisecond alternating unipolar pulse, where we stimulate at up to 15 milliamps in 4 blocks. Now our results, here's a patient where the EZ was determined to be in the medial orbital frontal region, and stimulating there. In the block design, what you see is a very nice regional and distal network of activation related to the stimulation going on there. And there is this interesting negative stimulation that you see distal to the activation. And as an example of the effect of the current level, that actually makes some sense, is that when you stimulate at a low current, you see a network being activated. When you move to a higher current, you see pretty much the same network areas being activated, but at a higher level. And along those lines, here's the time series from a voxel that was activated at both 4 milliamps and 8 milliamps, and you see a nice robust activation signature depending on the stimulation blocks, and it scales nicely with the current. Interestingly, when stimulating in the white matter, along the lines of, I guess, the fornicele activation that was discussed in the previous talk, you actually do get nice networks being activated, suggesting that the activation here is actually inducing current activations along the pathways connected by the white matter that's being stimulated. Interestingly, so what we did was we wanted to look at the correlation between the bold activation that we see while we're doing the stimulation. So what we did was we looked at all the contacts along the electrode that was left in the brain, looked at the induced voltage that we saw, and compared that to the t-value of the observed activation voxels very close to that particular contact. And what we see is a sort of a weak correlation, but extremely significant. So interestingly, so the first few cases that we did, we actually started out at 1 hertz, and after 3 cases, we saw no activation. So we decided to move to higher frequencies. And what we discovered was that unless one stimulates at higher than 20 hertz, we don't see any activation in response to the depth electrode stimulation. As an example of the specificity of the leptogenic zone, here's a typical case where we stimulated here, posterior to the corpus callosum, and you see a nice network being activated. And then we moved to leads that were very far away, more cortical, from what was determined to be the epileptogenic zone. And you see that, in fact, there's much less of a network activation, suggesting that this really is an EZ. Full disclosure, though, this is not that robust. There are cases where you don't get, when you determine the epileptogenic zone and you stimulate there, you do not always get widespread network activation, and sometimes the response can be quite weak. The effect of anesthesia, this was done not with bold monitoring. This was just done outside of the MR scanner. Simply, what we did was simply look at the signal in all of the other electrodes as not being stimulated, just monitored under anesthesia and without anesthesia. And just as an example, for epilepsy, the time range that we're interested in is this time period right here. Okay, and you see that under anesthesia, for almost all of the electrodes, there really was no difference with and without anesthesia. 7 of the 140 contacts that were monitored, we did actually see a pretty big effect, but we conclude that there's only a weak effect of of anesthesia on what we're looking at. Interestingly, we've also tried event-related designs. I described a block design, but when we try an event-related design, we get very similar activation with somewhat weaker maps. And the interesting thing here is once you do an event-related design, then you can play games like this, where what this is basically there's a 15-second interval between a 2-second stimulation for the event-related design. And what I'm showing here is the peak activation lagged by every 2 seconds for 15 seconds. And you see a very nice, interesting spatial distribution of activation after the stimulation. And this might shed some light into propagation patterns of epilepsy during a seizure. Showing the effect of laser ablation, what we did was basically did the stimulation in this area here, and you see activation. The electrode was removed, laser was inserted, and the tissue around the EZ was ablated. We then removed the laser, put the electrode back in, stimulated, and you see almost no activation remaining after the implantation. Now, we do a lot of work in DBS at the Cleveland Clinic, and just to show that some of this work can also be done using deep brain stimulation and using the context to stimulate. Shown here is a bilateral DBS implementation. Shown here is thalamic stimulation, where the thalamus is being stimulated to relieve essential tremor. When we do fMRI while doing this stimulation, what you see is a very nice activation pattern going all the way down to the subthalamic nucleus and extending up to sort of broad extended sensory motor areas. Stimulating the GPI and actually changing the contacts from the area that we think is effective to when it's not effective, you actually do see a spatial sensitivity to the exact spatial region of the stimulation. And again, playing the game of event-related stuff, this is again a movie of the activation pattern as a function of time after the stimulation in the thalamus. Again, we've extended this to other applications. We're working with some of the urologists who are using sacral stimulation, sacral nerve stimulation in the spinal cord to relieve some urologic disorders. And when we actually do the bold imaging while doing the sacral stimulation, we see again interesting activation patterns produced throughout the brain. So. I realize this is a very busy slide, but just really quickly to summarize the results that we've seen. We see strong regional and distal bold activation patterns. The activation patterns are suggestive of sensible underlying physiologic networks. We routinely get negative activation patterns, some of them suggestive of the default mode. White matter stimulation does also cause distal activation. There's a strong frequency dependence of this activation that stymied us somewhat at the beginning. Event designs seem to be promising for trying to understand the spatial relationship of the spread of these patterns. There's a current dependence that makes a lot of physiologic sense. We see a modest but highly significant correlation between the bold response and the corresponding electrophysiologic response monitored with the electrodes. We've done the safety testing and have demonstrated that this procedure now can be safely performed. And we've even looked at pathologic specimens postoperatively showing that there is no evidence of thermal damage in the tissue that's been excised. We see a mixed local response in the epileptic zone and has shown that the effect of anesthesia is pretty small. Our activation patterns are sensitive to the stimulation location, and the patterns are strongly altered by ablation, which is a good thing. Our future plans is to extend to multiple electrodes so that instead of just using one electrode, we could actually use more than one electrode doing the simultaneous fMRI. Also, to implement simultaneous recording and stimulation. At the moment, what we're doing is stimulating and then monitoring with bold. We're not actually recording during the MRI scanning. So there's some parameter optimization that can be done. We need to compare with the outcomes, some of the work that was shown earlier. We would like to move to actually stimulating awake patients. There's a lot of interesting things you can do there, and compare with other measures of connectivity. With that,